Good afternoon, dear students. Our lecture, Topical Issues of Diagnosis and Treatment of Ischemic Heart Disease in Outpatients. If you remember, ischemic heart disease classified like six forms: sudden coronary death, angina patterns, acute myocardial infarction, painless myocardial ischemia, heart failure, and disturbances of rhythm and conductivity. And according guidelines of on the management of stable coronary artery disease of the European Society of Cardiology, 6 variants occur in our clinical practice. And if you remember, ischemic heart disease due to imbalance between myocardial blood supply and oxygen demand. And coronary arteries supply blood to the heart muscle. The right coronary artery supplies both the right and the left heart. The left coronary artery supplies the left heart. Coronary circulation associated with right coronary artery and left coronary artery. Left coronary artery divided on anterior interventricular artery and circumflex artery. Ischemic heart disease or coronary artery disease is the most common form of the heart disease and the single most important cause of premature death in Europe, Russia, North and South America, Australia, and New Zealand. And coronary artery disease or ischemic heart disease due to imbalance between myocardial oxygen supply and oxygen demand, which associated with atherosclerosis of coronary arteries in 95 to 96% of all cases. Atherosclerosis is a progressive inflammatory disorder of the arterial wall that is characterized by focal lipid-rich deposits of atheroma that remain clinically silent until they become large enough to impair arterial perfusion or until ulceration or disruption of the region results in thrombotic occlusion of embolization of the affected vessel. In development of ischemic heart disease or coronary artery disease occur non-modifiable and modifiable risk factors. Uncontrolled or non-modifiable risk factors include age, more than 45 years, male gender, family history, genetic predisposition, and ethnic origin. And modifiable or controlled risk factors include dyslipidemia, arterial hypertension, smoking, diabetes mellitus, obesity, fatty food diet, physical inactivity, stress, and hyperestrogenemia in female. Endothelial dysfunction is the underlying process in atherosclerosis, from lesion initiation progression through to acute cardiovascular events. Endothelial dysfunction is caused by a variety of genetic factors as well as environmental factors that can be modified. The initiation trigger of the atherosclerosis appears to be injury of arterial endothelial cells from exposure to stimuli such as tobacco toxins, oxidized low-density lipoprotein, advanced glycation and products, elevated homocysteine, or infectious agent. Endothelial cell injury initiates a cascade of events resulting in cellular dysfunction. It is change in the balance of production of endothelial derivated vasoactive molecules. Circulatory leukocytes, predominantly monocytes, are attracted and bind to activated endothelial cell, followed by migration into the subendothelial layer, where they transform into macrophages. Extracellular lipid pool appears in the intimal space when these form cells die and release their contents. The earliest lesions are known as fatty streaks, which consist of lipid accumulating macrophages and form cells. These lesions may develop into fibrous plaques as a consequence of further lipid accumulation accompanied by local migration, proliferation, and fibrous transformation of smooth muscle cells. Further growth of the plaque initially causes outward remodeling of the vessel wall, thus minimizing the impact on the cross-sectional area of the lumen and the vessel's ability to deliver blood. However, progressive plaque accumulation results in luminal narrowing and ultimately vessel obstruction. Scheme of the development of atherosclerotic plaque include some steps. Earliest lesions as fatty streak without symptoms, future growth by lipid causes atheroma, which characterized by Angina Patterns, ulcerated plaque or rupture and occlusive thrombosis associated with acute syndromes, acute coronary syndrome, which include unstable angina or acute myocardial infarction. And scale score. Scale score we are used in our clinical practice for uh, estimation of unfavorable prognosis. And five main risk factors we are using scale SCORE. SCORE, Systematic Coronary Risk Evaluation. Risk stratification based on 5 main risk factors such as age, vertical line, sex, man or woman, third risk factors, smoking, fourth risk factors, systolic blood pressure, and fifth risk factors, total cholesterol level. According scale SCORE, green color associated with low risk, yellow color associated with moderate risk, red color associated with high risk, and dark red associated with very high risk of unfavorable prognosis of patients with ischemic heart disease. And patients with low risk, less than 1%, according scale SCORE, from 1 to 50% moderate risk of unfavorable cardiovascular events, unfavorable prognosis during 10 years. High risk from 5 to 10%, according to this scale SCORE, and more than 10% patients with very high risk of development of unfavorable prognosis, cardiovascular events during 10 years. And we are used in our clinical practice scale SCORE for definition of further our tactics and strategy in ischemic heart disease. In patients with high and very high risk of cardiovascular events, we consider angiography and further percutaneous coronary intervention. I think you know that this patient have a high risk of cardiovascular events. Man, first risk factors, non-modifiable, more than 45 second risk factors, and we don't know about genetic predisposition, but modifiable risk factors occur in this patient, such as smoking, fatty food diet, and obesity. And Angina Patterns, one of the most important variant of ischemic heart disease, and Angina Patterns is a symptom complex caused by transient myocardial ischemia and may occur whenever there is an imbalance between myocardial oxygen supply and demand. And usually, angina patterns occur when coronary artery obstruction more than 65% of diameter of vessel. Angina patterns is a medical term used to describe chest pain caused by poor blood flow to certain areas of the heart muscle. Often, the name is shortened to angina. Having angina means patient has an increased risk of having a heart attack, myocardial infarction. Angina can be useful warning sign if it makes you seek timely medical help and avoid a heart attack. Prolonged or unchecked angina can lead to a heart attack or increased risk of having a heart rhythm abnormality that could lead to sudden death. Time is very important in regard to angina. The more time patient heart is deprived of adequate blood flow and thus oxygen, the more heart muscle is at risk of heart attack or heart rhythm abnormalities. Classic clinical signs of angina patterns were described in 1768 year by Heberden. Myocardial ischemia is usually caused by coronary artery stenosis due to atherosclerosis, but may be caused by spasm, tachycardia, anemia, aortic stenosis or aortic regurgitation, left ventricle hypertrophy, or other reasons. This condition may coexist and will be exacerbated by physical exertion or emotional stress, which increase cardiac workload and energy requirement. Coronary artery spasm, in contrast, normally occurs at rest. Angina, typical chest pain, squeezing, burning, pressing. Heart is not receiving enough oxygen due to narrowed coronary artery, usually due to atherosclerosis of coronary arteries. If you remember, etiology of ischemic heart disease include, at first, coronary artery atherosclerosis. Coronary spasm is also called variant angina prince metal. Variant angina typically occurs when patient at rest, usually male, smoking, after 50 years, and prince metal angina characterized by night appearance at rest. But coronary artery atherosclerosis in 95 to 96% are caused by angina, causes angina. Critical blockage of coronary artery from atherosclerotic plaque build up when cholesterol or blood fats are too high or patient has other risk factors. Fat-like material called atherosclerotic plaque builds up in blood vessels. Eventually, the plaque will block blood flow through the vessel. Provoking factors of angina, exercise and emotional stress, decreased oxygen content in the air patient breathes may trigger angina. Low blood flow to the heart, which occurs when patients sleep, also can bring on angina. One of the reasons of angina, microvascular dysfunction, and discrepancy between the demand and supply of myocardial oxygen occur in tachycardia, left ventricle hypertrophy, anemia, arterial hypertension, and if you remember, first clinical signs of ischemic heart disease usually appears in obstruction of coronary arteries, more than 65% of diameter of vessel. And if you remember, non-coronarogenic diseases can cause angina, ischemia of myocardium, and can cause typical chest pain like angina patterns. And non-coronarogenic diseases in which occur angina patterns, arterial hypertension, left ventricle hypertrophy, aortic stenosis, the same discrepancy between oxygen supply and demand due to left ventricle hypertrophy, hypertrophic cardiomyopathy, dilated cardiomyopathy, paroxysmal tachyarrhythmias, anemia, hypoxemia, thyrotoxicosis. Ischemic cascade. Discrepancy between demand and delivery of oxygen can lead to myocardial ischemia, reduced pH, and the yield of potassium of cardiomyocytes. This process leads to increased intracellular capture and regional left ventricle contractility violation. Signs of global systolic and diastolic dysfunction. Ischemia associated with changes of ST segment. Subendocardial ischemia characterized by ST depression. Subepicardial ischemia characterized by ST elevation. And ischemia associated with pain attack. Ischemic cardiac chest pain characterized by some parameters. We must give characteristic of pain according to location, radiation, character, intensity, duration, provoking factors, and relieving factors. Angina Patterns, its clinical diagnosis. And angina patterns characterized by a deep and diffuse central chest discomfort. More often it's substernal, squeezing, burning, or pressing pain with duration 3 to 5 minutes, intensive pain with radiation to the left, to the neck, jaw or arm, scapula, left scapula, which arises after physical exertion and disappear after nitroglycerin intake or disappear at rest. Response to nitroglycerin will be almost immediate. Patients will not be able to point to where the pain is coming from with one finger, but will use an open palm or first over the center or left parasternal aspect of their chest. Dyspnea, fatigue, nausea may also represent underlying ischemia and can occur in the absence of the classical central chest pain. After inquiry, usually in 90% of all cases, we are suspect about Angina Patterns. Typical chest pain. And angina is often classified according to its temporal pattern and its relation to exertion because this closely reflects prognosis. Stable angina characterized by pain occurring after a relatively constant level of exertion. Stereotypical pain like answer on the same physical activity. Unstable angina characterized by pain of minor exertion or at rest, which is either new onset or dramatic worsening of existing angina. And in this table, you can see main features of a stable coronary artery disease. Stable anatomical atherosclerotic and or functional ulcerations of epicardial vessels and or microcirculation. Natural history includes stable symptomatic or asymptomatic phases, which may be interrupted by acute coronary syndrome, exacerbation of ischemic heart disease. Mechanism of myocardial ischemia. Fixed or dynamic stenosis of epicardial coronary arteries, microvascular dysfunction, focal or diffuse epicardial coronary spasm. The above mechanism may overlap in the same patient and change over time. Clinical presentation. Effort-induced angina caused by epicardial stenosis, microvascular dysfunction, vasoconstriction at the site of dynamic stenosis. Combination of the above. Rest angina caused by vasospasm, focal or diffuse, epicardial focal, epicardial diffuse, microvascular, combination of above. Asymptomatic because of lack of ischemia and or of the left ventricle dysfunction, despite ischemia and or left ventricle dysfunction. Stable angina more often occur in our clinical practice, like variant of ischemic heart disease. Stable angina is a repeating pattern of chest pain which has not changed in character, frequency, intensity, or duration for the several weeks. Stereotypical attacks on the same physical activity. The level of activity or stress that provokes angina is predictable and the pattern changes slowly. Stable angina is the most common form and it appears gradually. These patients have an increased risk of the heart attack, but an episode of stable angina does not indicate that a heart attack is about to happen. A crucial component of the management of the pain associated with angina patterns is identifying sources of stress and creating effective methods to minimize stress. Traditional clinical classification of the chest pain, typical angina, meets all three of the following characteristics. Substernal chest discomfort of characteristic quality and duration, burning, wheezing, substernal pain. Second characteristic, provoked by exertion or emotional stress, may occur in cold, in third characteristic, relieved by rest and or nitrates within minutes. Atypical probable angina occur when meets two of these characteristics, and non-angina chest pain lacks or meets only one or none of the characteristics. Non-coronary pain, cardialgia, not associated with atherosclerosis of coronary arteries. Atypical angina, probable angina, may occur in four categories of patients. Younger patients till 40, older patients more than 75 years, in females, and in diabetics, patients with diabetes mellitus. And stable angina classified according to Canadian Cardiovascular Society. First class, minimal limitation of ordinary activity. Angina occurs with rapid or prolonged exertion at work or unusual physical exertion. Ordinary activity does not cause angina, such as walking and climbing stairs. Angina with strenuous or rapid or prolonged exertion at work or recreation. Second functional plus, slight limitation of ordinary activity. Angina occurs on walking more than 200 meters or climbing stairs rapidly more than one floor, working in cold, in wind, or under emotional stress. Walking more than 2 blocks on the level and climbing more than one flight of ordinary stairs at a normal pace and in normal conditions. Third functional plus, marked limitation of ordinary physical activity. Angina occurs on walking from 100 to 200 meters or climbing one flight of stairs. Angina on walking 1 to 2 blocks, equivalent 100 to 200 meters, on the level or one flight of stairs in normal condition and at a normal pace. And fourth functional class of stable angina, characterized by inability to carry on any physical activity without discomfort. Angina symptoms may be present at rest. Metal angina or spontaneous or angiospastic angina is caused by vasospasm, a spasm that narrows the coronary artery and lessens the blood flow to the heart. Metal angina usually occurs in arteries already narrowed by atherosclerosis. In fact, most people with it have severe coronary atherosclerosis in at least one major vessel. The spasm usually occurs very close to the blockage. Unlike stable and unstable angina, metal angina usually occurs when a person is at rest or sleep, often at night, and not after physical exertion or emotional stress. It's associated with acute myocardial infarction, severe cardiac arrhythmias, including ventricular tachycardia and fibrillation, and sudden cardiac death. Usually, metal angina suffered males after 50, smokers with obesity. Microvascular angina or stable angina on angiographically intact vessels. Microvascular angina or syndrome X, not same with acute coronary syndrome, occurs when the patient experiences chest pain but has no apparent coronary artery blockage. This condition results from poor functioning of the teeny blood vessels that nourish the heart, arms, and legs. Microvascular angina can occur during exercise or at rest. Reduced vasodilator capacity of the coronary microvessels is thought to be a cause of angina during exercise. But the mechanism of angina at rest is not known. Coronary microvascular spasm and resultant myocardial ischemia may be the cause of chest pain in a subgroup of patients with microvascular angina. Microvascular angina characterized by three specific typical signs as classic angina pain, chest pain, diffuse substernal pressing, burning, squeezing chest pain with typical duration 3 to 5 minutes usually. ST segment depression on ECG during stress test, and angiographically normal coronary arteries without left ventricle dysfunction. And for confirmed diagnosis of microvascular angina, we are using angiography and echocardiography. Physical examination in ischemic heart disease. This rarely reveals any direct evidence of ischemic heart disease, but will help with risk stratification and to exclude coexisting disease. Measure to pulse rate, resting tachycardia, if present, usually represents activation of the sympathetic nervous system, but may be due to an arrhythmia precipitated by ischemia. Blood pressure measurement is essential to look for evidence of hypertension as a risk factor of ischemic heart disease. Precordial examination should include palpitation for the left ventricle hypertrophy, percussion for cardiac enlargement, and auscultation for added heart sounds. Examine for signs of hypercholesterolemia, the eyes for xanthelasmas, and skin for xanthoma. Deposition of lipids in skin. The history is the most important factors, confirmation, diagnosis. Laboratory methods, full blood count, full lipid profile, total cholesterol, low density lipoproteins and high density cholesterol and triglyceride level, blood glucose via use. Creatinine measurement and estimation of renal function are recommended in all patients. Fasting lipid profile recommended in all patients. If indicated by clinical suspicion of thyroid disorder, assessment of thyroid function is recommended. Liver function tests are recommended in patients early after beginning statin therapy. Brain natriuretic peptide measurement should be considered in patients with suspected heart failure. Annual control of lipids, glucose metabolism, and creatinine is recommended in all patients with no stable coronary artery disease. The main instrumental method of investigation, resting ECG, is recommended in all patients. Resting ECG in all patients during or immediately after an episode of chest pain suspected to indicate clinical instability of coronary artery disease. Echocardiography, resting transthoracic echocardiogram is recommended in all patients for exclusion of alternative causes of angina, for identification of regional wall motion abnormalities suggestive of coronary artery disease, measurement of the left ventricle ejection fraction for risk stratification purpose, evaluation of diastolic function. Ultrasound of the carotid arteries should be considered to be performed by adequately trained clinicians to detect increased intima media thickness and or plaque in patients with suspected stable coronary artery disease without known atherosclerotic disease. Ambulatory ECG monitoring for initial diagnostic assessment of stable coronary artery disease. Ambulatory ECG monitoring is recommended in patients with stable coronary artery disease and suspected arrhythmia. Ambulatory ECG monitoring should be considered in patients with suspected vasospastic angina. Holter monitoring ECG during 24 hours, 48 hours. Can use pharmacological test with dobutamine, myocardial perfusion scanning, computer tomography, and gold standard of diagnosis. Coronary arteriography, invasive method. Chest X-ray is recommended in patients with atypical presentation of or suspicion of pulmonary disease. Chest X-ray should be considered in patients with suspected heart failure. Exercise ECG is recommended as the initial test for establishing a diagnosis of stable coronary artery disease in patients with symptoms of angina and intermediate pretest probability of coronary artery disease, free of anti-ischemic drugs unless they cannot exercise or display ECG changes which make the ECG non-evaluable. Exercise ECG and exercise tolerance test is usually performed using a standard treadmill or bicycle ergometer protocol while monitoring the patient's ECG, blood pressure, and general condition. Planar or downsloping ST segment depression of 1 mm or more is indicative of ischemia. Management based on risk determination for prognosis in patients with chest pain and suspected stable coronary artery disease. risk stratification of unfavorable prognosis, for definition of risk, we use scale score, and in this scheme, if confirmed diagnosis stable coronary disease and pretest probability consists of 15 to 85%, test information will already be available. If pretest probability more than 85%, additional testing for risk stratification only in patients who have mild symptoms with medical management but following adequate information wish to proceed to revascularization in case of high risk. If low event risk, mortality less than 1% per year, we use optimal medical therapy. If symptoms improved, we continue optimal medical therapy. If we reveal intermediate event risk, mortality more than 1% but less than 3% per year, we use trial of optimal medical therapy and consider invasive coronary angiography based on comorbidities and patients' preferences. And if we review high event risk, mortality more than 3% per year, we are using invasive coronary angiography and consider revascularization when appropriate. And management of stable angina patterns directs with the purpose of increased duration of life by means of prevention of myocardial infarction, improve quality of life by means of decrease quantity and durations of attacks, increase tolerance to physical exertion. Measures involve lifestyle modification, removal risk factors, pharmacological therapy, and invasive treatment including percutaneous transluminal coronary angioplasty and intracoronary stents and coronary artery bypass graft. Definition of risk for various test modalities. High risk during exercise stress test, exercise stress ECG. If we reveal in high risk cardiovascular mortality more than 3% per year, intermediate risk cardiovascular mortality between 1 and 3% per year, and low risk cardiovascular mortality less than 1% per year. And ischemia imaging, high risk area of ischemia more than 10%, limited quantitative data for cardiac magnetic resonance, probably more than 2 over 16 segments with new perfusion defects of more than 3 dobutamine-induced dysfunctional segments. Intermediate risk in case when area of ischemia between 1% to 10% of or any ischemia less than high risk by cardiac magnetic resonance or stress echo, and low risk no ischemia. Coronary computed tomography angiography. High risk, significant lesions of high risk category, 3 vessel disease with proximal stenosis, left main and proximal anterior descending coronary artery disease. Intermediate risk, significant lesion in large and proximal coronary artery, but not high risk category. And low risk if normal coronary artery or plex only. Risk stratification using ischemia testing. Risk stratification is recommended based on clinical assessment and the result of the stress test initially employed for making a diagnosis of stable coronary artery disease. Stress imaging for risk stratification is recommended in patients with non-conclusive exercise ECG. Risk stratification using stress ECG, unless they cannot exercise or display ECG changes which make the ECG non-evaluable, or preferably stress imaging if local expertise and availability permit, is recommended in patients with stable coronary disease after a significant change in symptom level. Stress imaging is recommended for risk stratification in patients with known stable coronary artery disease and deterioration in symptoms if the site and extent of ischemia would influence clinical decision making. Pharmacological stress with echocardiography or single photon emission computed tomography should be considered in patients with left bundle branch block. Stress echocardiography or single photon emission computed tomography should be considered in patients with paced rhythm. Risk stratification by invasive or non-invasive coronary arteriography in patients with stable coronary artery disease. Invasive coronary angiography is recommended for risk stratification in patients with severe stable angina, more than third functional class or same, or with a clinical profile suggesting a high event risk, particularly if the symptoms are inadequately responding to medical treatment. Invasive coronary angiography is recommended for patients with mild or no symptoms with medical treatment in whom non-invasive risk stratification indicates a high event risk and revascularization is considered for improvement of prognosis. Invasive coronary angiography should be considered for event risk stratification in patients with an unconclusive diagnosis or non-invasive testing or conflicting results from different non-invasive modalities. If coronary computed tomography angiography is available for event risk stratification, possible overestimation of stenosis severity should be considered in segments with severe calcification, especially in patients at high intermediate pretest probability. Additional stress imaging may be necessary before referring a patient with fewer or no symptoms to invasive coronary angiography. Management of stable angina include pharmacological and invasive strategy. And non-pharmacological management include lifestyle modification, removal risk factors for all patients, recommended diet intakes, saturated fatty acids to account for less than 10% of total energy intake through replacement by polyunsaturated fatty acids. Trans-unsaturated fatty acids less than 1% of total energy intake. Less than 5 grams of salt per day. 30 to 45 grams of fiber per day from whole grain products, fruits and vegetables. 200 grams of fluid per day. 2 to 3 servings. 200 grams of vegetables per day. 2 to 3 servings. Fish at least twice a week, one being oily fish. Consumption of alcoholic beverages should be limited to 2 glasses per day, 20 grams per day of alcohol for men, and 1 glass per day, 10 grams per day of alcohol for non-pregnant women. And this patient needs in removal risk factors. Decrease fatty food diet, no smoking, decrease body weight, example of diet. Vegetables and sea products. Pharmacological management of patients with stable coronary artery disease. The main principles of pharmacological therapy: stop pain, decrease quantity and duration of attacks of angina, pectoris, prevention of progression of angina pectoris, prevention of the development of myocardial infarction and sudden death. The main tasks for realization of the principles of pharmacological management: first, increase of coronary circulation; second, decrease myocardial oxygen demand; third, improve rheological properties of blood; fourth, improve myocardial metabolism. Two main ways of pharmacological management. First way, angina relief, and second way, event prevention. For angina relief, sublingual nitroglycerin or isocat spray is the drug of choice in acute attack. Short-acting nitrates. And plus anti-ischemic therapy. Anti-ischemic therapy, first line of anti-ischemic drugs, beta blockers and or calcium channel blockers. Beta blockers or calcium channel blockers are heart rate decrease, verapamil or diltiazem. Consider calcium channel blockers dehydropyridine origin if low heart rate, amlodipine, felodipine, lercanidipine, or intolerance or contraindications for beta blockers. Consider combination of beta blockers and calcium channel blockers dehydropyridine origin if stable angina more than second functional class, according to Canadian classification of functional classes. Anti-anginal, anti-ischemic drugs for prevention of further attacks, such as beta blockers, long-acting nitrates, or calcium antagonists. If no effect, second line of anti-ischemic drugs include ivabradine, long-acting nitrates, nicorandil, ranolazine, trimetazidine. Second line may add or switch if first line for some cases no effect. No effective. If combination of 3 or more drugs, first line plus second line, no effective, we are consider angiography and percutaneous coronary intervention with stenting or CABG, coronary artery bypass graft. Second way of management of stable coronary artery disease, drugs which improve prognosis. And for all patients we use lifestyle modification, change of life, and control of risk factors, minimization of risk factors. and education of patient. And drugs which improve prognosis: antiplatelets, aspirin or clopidogrel, low dose 75 to 150 milligram. Aspirin reduce risk of adverse events such as myocardial infarction and should be prescribed for all patients with ischemic heart disease. And second group of drugs which improve prognosis: hyperlipidemic drugs, statins. Atorvastatin, rosuvastatin, simvastatin, and for prevention of remodulation of myocardium, we are consider AC inhibitors or angiotensin receptor blockers. These medicines reduce mortality by approximately 1/3 in all risk groups. How we choose correct tablets? Optimal medical treatment indicates at least one drug for angina relief plus drugs for event prevention. It's recommended to educate patients about the disease, risk factors, and treatment strategy. It is indicated to review the patient's response soon after starting therapy. Angina or ischemia relief: short-acting nitrates, sublingually nitroglycerin or isotate spray. First-line treatment is indicated with beta blockers and or calcium channel blockers to control heart rate and symptoms. For second-line treatment, it's recommended to add long-acting nitrates or ivabradine or nicorandil or ranolazine according to the heart rate, blood pressure, and tolerance. For second-line treatment, trimetazidine may be considered. According to comorbidities, it is indicated to use second-line therapies as first-line treatment in selected patients. In asymptomatic patients with large areas of ischemia, more than 10%, beta blockers should be considered. In patients with vasospastic angina, calcium channel blockers and nitrates should be considered and beta blockers avoided. For event prevention, low-dose aspirin daily is recommended in all patients. Clopidogrel is indicated as an alternative in case of aspirin intolerance. Statins are recommended in all patients. It is recommended to use AC inhibitors or angiotensin II receptor blockers if presence of other conditions, heart failure, hypertension, or diabetes, for prevention of remodulation of myocardium. Treatment in patients with microvascular angina is recommended that all patients receive secondary prevention medications, including aspirin and statins. Beta blockers are recommended as a first-line treatment. Calcium antagonists, verapamil and diltiazem, are recommended if beta blockers do not achieve sufficient symptomatic benefit or are not tolerated. If you remember, beta blockers contraindicated in bronchial asthma, in sick sinus syndrome, in complete AV block second to third degree, in bradycardia less than 55, and AC inhibitors or nicorandil may be considered in patients with refractory symptoms. Nicorandil combination of combined drugs, which consist of nitrates and potassium activator. Xanthine derivatives or non-pharmacological treatments such as neurostimulatory techniques may be considered in patients with symptoms refractory to the above listed drugs. Revascularization. Hard-team approach to revascularization is recommended in patients with unprotected left main, 2 to 3 vessel disease, diabetes, or comorbidities. Left main more than 50% diameter stenosis. Any proximal left artery, left anterior descending, more than 50% diameter stenosis. 2 to 3 vessel disease with impaired left ventricle function in chronic heart failure. Single remaining vessel, more than 50% diameter stenosis. Proven large area of ischemia, more than 10% of the left ventricle. Any significant stenosis with limiting symptom or symptoms non-responsive, intolerant to optimal medical therapy. Dyspnea, heart failure with more than 10% ischemia, viability supplied by stenosis more than 50%. No limiting symptoms with optimal medical therapy in vessel other than left main or proximal left anterior descending or single remaining vessel, or a vessel subtending area of ischemia less than 10% of myocardium. Follow-up of revascularized stable coronary artery disease patients. General measures it is recommended that all revascularized patients receive a secondary prevention and be scheduled for follow-up visit. It's recommended to instruct patients before discharge about return to work and reuptake of full activities. Patients have to be advised to seek immediate medical contact if symptoms. Antiplatelet therapy. Single antiplatelet therapy, usually aspirin, is recommended indefinitely. Dual antiplatelet therapy is indicated after bare metal stent for at least 1 month. Dual antiplatelet therapy combination aspirin plus clopidogrel. Dual antiplatelet therapy is indicated for 6 to 12 months after second generation drug-eluting stent. Dual antiplatelet therapy may be used for more than 1 year in patients at high ischemic risk, such as stent thrombosis, recurrent acute coronary syndrome, dual antiplatelet therapy, post-myocardial sclerosis, and low bleeding risk. Dual antiplatelet therapy for 1 to 3 months may be used after drug-eluting stent implantation in patients at high bleeding risk or with undeferrable surgery or concomitant anticoagulant treatment. In symptomatic patients, stress imaging, stress echocardiography, magnetic resonance imaging, or myocardial perfusion scintigraphy is indicated rather than stress ECG. In patients with low-risk ischemic finding less than 5% of the myocardium at stress imaging, optimal medical therapy is recommended. In patients with high-risk ischemic finding, more than 10% of myocardium, at stress imaging coronary angiography is recommended. Late 6 months stress imaging test after revascularization may be considered to detect patients with restenosis after stenting or graft occlusion, irrespective of symptoms. After high-risk PCI, percutaneous coronary intervention, late 3 to 12 months, control angiography may be considered irrespective of symptoms. Systematic control angiography early or late after PCI is not recommended. Testing in asymptomatic patients at risk for stable coronary artery disease. In asymptomatic adults with hypertension or diabetes, a resting ECG should be considered for cardiovascular risk assessment. In asymptomatic adults at intermediate risk, measurement of carotid intima media thickness with screening for atherosclerotic plaques by carotid ultrasound measurement of ankle branchial index or measurement of coronary calcium using CT should be considered for cardiovascular risk assessment. In asymptomatic adults with diabetes, 40 years of age and older, measurement of coronary calcium using CT may be considered for cardiovascular risk assessment. In asymptomatic adults without hypertension or diabetes, a resting ECG may be considered. In intermediate risk asymptomatic adults, see score for definition of intermediate risk, including sedentary adults considering starting a vigorous exercise program. An exercise ECG may be considered for cardiovascular risk assessment, particularly when attention is paid to non-ECG markers such as exercise capacity. In asymptomatic adults with diabetes or asymptomatic adults with a strong family history of coronary artery disease, or when previous risk assessment testing suggests high risk of coronary artery disease, such as coronary artery calcium score of 400 or greater, stress imaging tests MRI, stress echocardiography, perfusion, CMR may be considered for advancing cardiovascular risk assessment. In low or intermediate risk, based on scale score, asymptomatic adult stress imaging tests are not indicated for further cardiovascular risk assessment. Reassessment in patients with stable coronary artery disease. Follow-up visits are recommended every 4 to 6 months in the first year following institution of therapy for stable coronary artery disease, which may be extended to 1 year afterwards. Visits should be to the general practitioner who may refer to the cardiologist in case of uncertainty. These visits should include a careful history and biochemical testing as clinically appropriate. An annual resting ECG is recommended and an additional ECG if a change in anginal status occurred or symptoms suggesting an arrhythmia appeared or medication has been changed, which might alter electrical conduction. An exercise ECG or stress imaging, if appropriate, is recommended in the presence of recurrent or new symptoms once instability has been ruled out. Reassessment of the prognosis using stress testing may be considered in asymptomatic patients after the expiration of the period for which the previous test was felt to be valid guaranteed period. Repetition of the exercise ECG may only be considered after at least 2 years following the last test, unless there is a change in clinical presentation. Remember about effectiveness of pharmacological management of the stable angina patterns. First criteria: decrease quantity and duration of acute attacks of angina patterns on 50%. Second criteria: reduction quantity of tablets of nitroglycerin during day and week. Third criteria of effectiveness of pharmacological management: removal angina at rest. Fourth criteria of effectiveness of pharmacological treatment of stable angina: increased tolerance to physical exertion. And fifth criteria of effectiveness of pharmacological management of stable angina: decrease quantity of episodes of painless ischemia, silent ischemia of myocardium according ECG monitoring on 50%. Thank you for your attention. Be healthy. I wish you success, dear students.